Hey, everybody. Hopefully you can hear me okay. All right, awesome. Thanks for the introduction, Shakti. So today I'll be taking you through a very exciting whirlwind of respiratory mechanics. I recognize this stuff can be really dry, but I do think it serves an extremely important purpose in not only preparation for your boards, but also in the day-to-day management of patients at the bedside. So at the core of it, it's not the most exciting stuff, but it's a really strong foundation for managing our ventilator and respiratory support dependent babies. So we're going to focus on the basic principles of respiratory mechanics, but for reference here, I included some of what I would call some intermediate principles that also deserve their own talk, but won't be able to get to today for the sake of time. Just putting them on there so kind of get the complete picture. These are our brief, maybe not so brief objectives. And I have no disclosures. Of course, respiratory is a huge topic on the boards. Represents the highest percentage of content relative to everything else. And the boards love to test physiology. So this is why these concepts are super important. So this is the framework we'll use today to think about respiratory mechanics. We'll start with how the air moves, focusing first on resistance and airflow, and then build into how the lung behaves with compliance, functional residual capacity, and pressure volume relationships. Also how timing affects ventilation, and finally how the lung recoils. But everything really starts with airflow. So we'll begin with resistance. Um, so starting with resistance, which is the basis of what determines airflow. Now, resistance is the opposition of flow caused by friction. So if you have resistance, you can't have good flow. Or if you have too much resistance, you can't have good flow. Resistance or airflow is primarily determined by the flow pattern, which we will break down a little bit later, and also the gas properties of density and viscosity. But the most important factor by far is the radius. Because resistance is inversely proportional to the fourth power of the radius, as you can see here, even very small decreases in airway size, like edema, secretions, or an endotracheal tube, can really dramatically increase your resistance, and therefore your work of breathing and your CO2 retention. In neonates, the majority of the resistance comes from the airway, especially the nasal passages, followed by the chest wall, and then just the inherent lung tissue. And this is really important clinically because it means that even small changes in airway patency or things like nasal stuffiness can impact ventilation. Poiseuille's law, and I'm probably saying that incorrectly, is how we just can describe resistance mathematically. And this is one of those formulas that will show up on the boards. Resistance is governed primarily by airway radius and is inversely proportional to the radius of the fourth power, as I showed before. And also contributing, but less so, are gas viscosity and the airway length. So because of this, the resistance is inversely proportional to the fourth power of the radius, again, just to hammer it home, and meaning that even very small decreases in airway caliber lead to dramatic increases in resistance. And you can see this in practice. So a small diameter ET tube, your 2.0, 2.5s, have significantly higher resistance versus your larger 3.54s. Any secretions or edema in the airway can quickly worsen your ventilation, and neonates already inherently have much higher resistance because their airways are so much smaller. And then conversely, even something as simple as shortening or cutting the ET tube, which I know we don't all do as much anymore, can reduce resistance because it decreases the length of the airway, that L. But while all these variables matter, the radius still overwhelmingly drives what we see clinically. So the bottom line is that the higher the resistance, the harder it is to move air. And that's why understanding this concept of resistance is so incredibly important. It's determined by the airway size, the flow pattern, the gas properties. And when the resistance goes up, the airflow becomes less efficient. So you need more work to achieve the same ventilation, whether that's by the baby or by the ventilator. Poiseuille's law tells us about resistance under what we would call ideal flow conditions, but airflow is not always ideal. So let's talk about the different ways that gas can move through the airway. So the movement of gas or airflow can be smooth and efficient, or it can become chaotic and much less efficient. And that's where the concept of laminar flow and turbulent flow come in. And we'll break these down one by one. So laminar flow creates a very predictable low type of resistance that can achieve high velocities. So this type of flow occurs in the narrower or smaller but longer airways and during quiet and calm breathing. So this is again your ideal state of flow. In this pattern, the gas moves in these smooth parallel layers that you could see up top with kind of a parabolic velocity profile. It's slow near the airway walls and then fast in the center. So it allows the energy to be transmitted very efficiently with minimal energy loss. And that's what leads to that low resistance profile. Again, the resistance here follows Poiseuille's law and is directly proportional to the inverse of the radius of the fourth power, just like we talked about before. And I just want to kind of highlight something is just to make sure we don't get confused. I just told you that laminar flow is low resistance, but it occurs in the small and narrow airways, which I always found a little bit confusing, and I think can sound a little bit contradictory because the smaller the radius, the higher the resistance, right? But overall, laminar flow is inherently low resistance for this type of airway. And because if you think back to your general physics, distal airways are numerous and they're arranged in parallel, the sum of their total resistance remains low and the flow stays laminar. So on the flip side, turbulent flow represents a high resistance, inefficient pattern of airflow, this making the flow of gas or air slower here. It's seen in the wider airways and at certain branch points, and then clinically also seen with crying, agitation, subglottic narrowing or edema. So it represents a high resistance, inefficient pattern of airflow and where the gas kind of moves in these swirly, disorganized patterns rather than smooth layers. And in this setting, there's a lot of loss of energy to the internal mixing. So a much higher pressure gradient is required to generate and maintain the flow. And unlike the there we go. Unlike the laminar flow, resistance increases non-linearly with factors like flow velocity and airway narrowing and changes in gas density. So it does not follow Poiseuille's law. So this is one of those non-ideal states. So clinically means that as the airflow becomes more turbulent, such as in the larger airways or in the presence of obstruction, the resistance rises really sharply and the work of breathing increases, often out of proportion to small changes in the airway caliber. This is, just tied into clinical practice. So a lower gas density, so using something like Heliox can reduce your turbulence. Also minimizing agitation, keeping the baby calm can help to maintain smoother, more efficient airflow, which of course we see in clinical practice with the use of sedation. Now observing this clinically, so getting into flow volume loops and kind of how we interpret the quality of our airflow. Flow volume loops on the ventilator, which depending on which ventilator interface you have seen in some capacity. These help us determine whether the air is moving easily in and out. So flow volume curves depict volume on the x-axis and then the flow on the y-axis. The expiration loop is above the x-axis and then the inspiration loop is below the x-axis. If the expiration is unimpeded, it should really closely mirror the inspiration and it should be seen as a relatively symmetric kind of circular loop. But when disease states exist, the curves are going to be altered, like I'm going to show you. So as resistance increases, airflow becomes limited because we said that a resistance is essentially how easy or hard it is to move air. So what happens when there's increased resistance is that during expiration, flow becomes limited, creating that classic scooped or ski slope appearance. This reflects impaired expiratory flow due to the increased airway resistance, and there's in the expiratory phase, the air is going to empty more slowly out of your airway. And we commonly see this in conditions like BPD, where there's airway narrowing from inflammation or from bronchospasm, and then also potentially dynamic airway collapse. So there's uneven and prolonged emptying. So the key issue here, the bottom line is that the key issue here isn't really getting in getting air in, it's the inability to get the air out efficiently. And expiratory flow limitation happens also because your positive intrathoracic pressure during exhalation compresses those already narrowed or collapsible airways, leading to more collapse. Whereas in inspiration, the limb's not really going to be affected because in inspiration, you're actually going to pull those airways open with the decrease in intrathoracic pressure. So in contrast to your obstructive patterns like BPD, restrictive lung disease is characterized by reduced lung compliance, so less air is able to enter the lungs during inspiration overall. So this results in overall a smaller, narrower loop, reflecting reduced lung volumes. Here, the air is actually expelled relatively quickly, so the expiratory limb remains smooth without the scooped out or ski slope appearance. And the key issue isn't airflow limitation, it's the inability to get sufficient volume into the lungs in the first place, which is why the inspiratory limb also looks very thin. So moving on to compliance. So far we focused on how the air moves through the airways and what limits that movement. Now we're going to be shifting into what happens once the air actually reaches that lung, how easily the lung can expand. And that's what brings us to the compliance and the representation of compliance on the pressure volume curves. So compliance describes how easily the lung expands and fills with air in response to a certain pressure. So it's the change in volume for a given change of pressure. When your compliance is high, the lungs, it's a good thing to a point. The lungs can expand easily, meaning that you can achieve a large increase in the volume with only a small increase in pressure. And on the pressure volume curve, this corresponds to a steeper slope of your loop. Conversely, when your compliance is decreased, the lungs are stiff and they're harder to expand. So to get the same change in volume, you would need much more pressure. And on the pressure volume curve, this appears flatter on your ventilator, reflecting that reduced distensibility. So clinically, you can think of low compliance lungs as stiff, small lungs that require higher pressures to ventilate, your RDS lungs, which directly translates to increased workup breathing. Decreased compliance is seen in acute lung disease, like I mentioned, where the lungs are stiff and smaller in volume, so things like RDS or even pulmonary hypoplasia. And in these situations, the lung can't expand easily. So for a given change in pressure, you get less change in volume, and then conversely, if you want to achieve the same volume, you need to apply more pressure. That's why these patients are harder to ventilate. So the issue isn't airflow through the airway, but just the lungs' inability to expand. As a result, you need high pressures to achieve adequate ventilation, and the work of breathing increases really significantly. So on the ventilator, we'll see this as lower tidal volumes at a given pressure, or the need to increase our pressures to achieve adequate ventilation or a specific tidal volume. So RDS is typically a heterogeneous disease, as we've heard before, so meaning that different regions of the lung are affected to varying degrees. In the most diseased lung areas, you see both alveolar and airway collapse. So this leads to kind of an overall smaller effective radius, which increases your resistance locally while also giving you poor gas exchange and decreased compliance. The underlying problem, of course, is a surfactant deficiency. So normally, as we all know, your surfactant lowers your surface tension within the alveoli. Without it, you get a higher surface tension and the alveoli collapse more easily, leading to atelectasis and just stiff, poorly compliant lungs. And the mathematical concept that helps explain this, which again is highly testable, is your Laplace's law. Laplace's law tells us that the pressure required to keep an alveolus open is proportional to the surface tension and inversely proportional to the radius. So again, that radius comes into play. So as the surface tension increases and the alveoli become smaller, the collapsing pressure rises pretty dramatically, making these gas exchange units very difficult to keep open. But then when you give your surfactant, your surface tension decreases and really pretty dramatically so, and the alveoli begin to reopen. However, this recruitment also can be uneven, and some regions can open really quickly while others stay collapsed. So it actually increases the risk of overdistension in the more compliant areas because the gas will move preferentially from areas of higher pressure and surface tension to those areas that have gotten to surfactant that have the lower surface tension. So you can actually increase your risk of pneumothorax in those already over compliant areas. So also important to remember that in neonates, the chest wall behaves very differently than in adults. Neonatal chest wall is much more compliant and therefore more collapsible. This is due to a couple of factors. So one being poorly mineralized ribs, decreased diaphragm strength, and also reduced muscle mass. And because of this, the chest wall provides less outward recoil to oppose the lung's natural tendency to collapse. So as a result, there's a greater tendency toward atelectasis. It's where your visible retractions come from, and even sometimes paradoxical chest wall movement during breathing. So this makes maintaining lung volume much more challenging. So as I mentioned, the pressure volume curve, here compliance is essentially reflected by the slope of this curve. These curves illustrate how lung volume changes in response to an applied pressure throughout the respiratory cycle. And these are, the curves that I think we look at every day on our ventilated babies, or at least should be looking at every day on our ventilator babies, many times a day. There's two limbs to the curve. The inflation or the inspiratory limb reflects what happens as the pressure increases and the alveoli are gradually recruited and opened. And then the deflation or the expiratory limb reflects what happens as the pressure decreases and the alveoli begin to close. But really important concept is that that slope is not the same during inflation and deflation, and that's where the concept of hysteresis becomes clinically meaningful. So this is hysteresis is the area where the two limbs do not overlap, and the reason that this exists is that the lung doesn't behave like a perfect elastic balloon. So it takes much more pressure to open the collapsed alveoli during inflation than it does to keep them open once they've already been recruited. So on exhalation, the lung maintains volume at a lower pressure than was required to achieve the same volume during inhalation. And clinically, this is important because it highlights why recruitment and maintenance of the alveolus are not the same thing. So opening the lung requires more pressure, but once it's open, having an adequate level of PEEP will help keep the alveoli open and prevents kind of repeated collapse and the concept of atelectotrauma. So looking at these curves, this highlights again how compliance differs between a normal lung and one with RDS. So in a normal term newborn lung, once your lung is recruited, a relatively large tidal volume can be achieved with just a small change in pressure. So that's what you see with the green loop. So this reflects good compliance where the lungs expand easily. In contrast, in RDS and in surfactant deficiency, the lung is much stiffer. That slope is lower. More horizontal. Ventilation occurs on the lower, flatter portion of the curve, so it takes much more pressure to generate a relatively small volume. So for your change, a large change in X required to achieve a small change in Y, and that's the red curve. And if you compare the slopes of these dashed lines, this becomes pretty clear because the flatter the slope, the worse the compliance. And the more pressure required to achieve good ventilation. So now once most alveoli are open, further pressure doesn't really do too much for you except for stretch the alveoli walls, and compliance decreases again due to overdistension. So you actually only get a really small change in your volume for a relative change in pressure, but you don't actually open the alveoli anymore. So if you keep going with this, you end up getting this narrowing up here that you can see on the ventilator, which is called beaking. So one of the most important things to remember is that also that ventilator loops are dynamic. They can change from breath to breath, not just from day to day, but literally from breath to breath. So rather than looking at a single loop in isolation, where we should be constantly interpreting patterns and trends. And besides the speaking, there's a few features to look for. If the curve appears very flat at the bottom, that suggests incomplete recruitment. So your alveoli are probably not fully open at the end of expiration, and it indicates that you need to increase your PEEP to maintain that lung volume. You should also be alert for, oh, sorry, that somebody said something. You should also be alert for distorted or irregular loops, which can indicate leaks or patient ventilator asynchrony. Kind of left to right shifts in the loop are also important. A rightward shift reflects decreased compliance or stiffer lungs, as we might see with worsening RDS. And then a leftward shift indicates your improved compliance, such as after surfactant administration, and can signal that maybe it's time to wean your ventilator. So these loops can really help you kind of guide real-time ventilator adjustments, even without a readily available blood gas. Now let's for a minute just look at just the inspiratory limb of that pressure volume curve to talk about FRC. So FRC, functional residual capacity, is the resting lung volume at the end of expiration. So where the inward recoil of the lungs kind of balances that outward recoil of the chest wall. So on the pressure volume curve, this point lies on the most compliant vertically linear portion of the deflation limb. So that's important because starting a breath from here means that you can achieve a large change in volume for a relatively small change in pressure, making your breathing more efficient. So clinically, this translates to lower work of breathing and spontaneously breathing patients and lower pressures needed during mechanical ventilation in intubated babies. So that's why our goal with PEEP is to maintain in expiratory volume at this optimal point on the pressure volume curve, preserving the FRC and maximizing compliance and minimizing lung injury. So to kind of sum it up, FRC is the most energy efficient volume for breathing. The work required to inflate the lungs from this point is at its minimum. In surfactant deficiency or RDS, a low compliance leads to a reduced FRC because your alveoli are closed. And then after surfactant, improved compliance shifts the curve to the left, restoring FRC at lower pressures. So the reason that all this is clinically relevant, again, is not so much that the curve itself tells you what PEEP to set per se, but if you see that the curve has shifted left or right as the disease process changes, whether it's because of surfactant administration or something you've done for the baby, or because of just progressive lung disease with BPD, you know that you should make an adjustment in your PEEP so you're giving adequate FRC. Now, moving on to the concept of a time constant, which is really the most math-heavy section. So timing matters in ventilation, and this is reflected in the concept of the time constant. So we already know that resistance tells us how hard it is to move air, and compliance tells us how much the lung expands. But neither of those things really tell us how quickly inflation or exhalation occur. So that's where the time constant comes in. So the time constant represents how quickly a lung unit can inflate and deflate, essentially. It represents the time it takes for alveolar and airway pressures to equilibrate. And mathematically, the time constant is really just the resistance multiplied by the compliance. So because of that, it's directly related to both. If one increases, the time constant also increases. If either one increases, the time constant increases. So anything that makes it harder to move air in and out of the lung, or anything that allows the lung to hold more volume, will slow down filling and emptying. And the time constant is expressed in seconds, so because it's literally a measure of time. In low compliance states like RDS, the time constant is short. These are stiff lungs that don't take in much volume and they want to empty quickly. So we use for these babies, as you already know, higher rates, shorter inspiratory times, and lower tidal volumes of about 4 to 6 mLs per kilo. But this is where our sort of concept of BPD vent settings comes in. So in these high resistance states like BPD, the time constant needs to be long because these lungs not only fill, but particularly empty really slowly. So we need to give them time, and that is achieved by lower rates, longer inspiratory times, and adequate tidal volumes and higher PEEP. And remember, especially in BPD, the lung is heterogeneous. Different lung regions themselves may behave very differently within the same patient with different time constants for each area of the lung. So at the bedside, knowing the time constant can help us match the ventilator to the lung. So fast and gentle strategy for your stiff lungs, and then slower with more time for those obstructed lungs. So one time constant is also defined as the measure of the time necessary for the alveolar pressure to reach 63% of the change in airway pressure. But note here that it takes 3 time constants to inflate or deflate 95% of the lung, and 5 time constants to deflate 99% of the lung. So if your I time is not greater than 3 time constants, there may be inadequate delivery of the tidal volume or incomplete expiration, leading to gas trapping, inadvertent peeping, and then, of course, hypoxia and hypercarbia. So again, RDS is low compliance, high resistance pathology. So just kind of talking through a mathematical example. So you can see here that the time constant is 0.05 seconds, relatively short. And you can see the math down here to show that we got this number from the product of the resistance and the compliance. So, and then you remember you want to wait at least 3 to 5 time constants before giving the next breath, so the lung can completely empty before giving the following breath. So in this case, the expiratory time should be 0.15 to 0.25 seconds, or 3 to 5 times the time constant. In this next scenario, this is along with BPD, which is a low compliance and very high resistance pathology. So you're going to have a much larger time constant here, and that time constant is 0.2 seconds, which means that your expiratory time would be 3 to 5 times that, or 0.6 to 1 seconds. And I put a star by the 1 second time because in the next slide, I want to kind of show you how an E time of 1 second would look like in real life for a baby with BPD. So thinking about this in a stepwise fashion, it all starts with the cycle time, which is determined by the respiratory rate. And the cycle time is just 60 divided by the respiratory rates and on the vent. And the cycle time is measured in seconds as well, and it includes inspiration and expiration. So from there, if we know we need an I time of about 1 second from the previous slide for this baby with BPD, for adequate exhalation to occur, we subtract that from the total cycle time to determine what the I time should be. And remember, on the vent, you're setting the I time, not the E time. So this is how you use that information to guide your settings. So this is your math for a patient with BPD. So to achieve an E time of 1 second, you're going to set a 1-to-1 I to E ratio with a respiratory rate of about 30. In most other cases, though, this calculation leads to an I time of about 0.5 seconds. Which gives you an IDE ratio of about 1 to 2, which is a physiologic and efficient target for conventional ventilation. So when you run through that math, it typically corresponds to a respiratory rate of about 40 breaths per minute, which kind of fits well with standard neonatal ventilation strategies in the early period. So last but not least, elastance. So elastance is the concept that tells us how a lung recoils once it's been inflated. Um, so elastance is the tendency for tissue to return to its original size or shape. It's a measure of the lung's resistance to being stretched, representing, again, its tendency to go back to its original size, versus compliance, which is, remember, it's the pressure you need to open the lungs. And the formulas really are just inverses of each other. And elastance is what makes exhalation a passive phase, um, which I'll talk more about in a little bit. But elastance can be described by Boyle's law, which you'll also need to remember for your boards, and maybe you already remember from way back in general chemistry. I didn't, but you do. But it states that the pressure and volume of a gas are inversely proportional. So as volume increases, pressure decreases, and then as volume decreases, pressure increases. And we'll talk about how that applies clinically. So just stepping back for a second and thinking about the basic mechanics of breathing. So what happens when you take a breath? So during inspiration, the diaphragm and the intercostal muscles contract, which increases your thoracic volume. And then as that chest expands, the intrapulmonary pressure falls below the atmospheric pressure, and then air is able to flow into the lungs and down that pressure gradient. So that's why inspiration is an active process. It requires energy and muscle contraction. But in contrast, as I said before, expiration is passive. So as the muscles relax, your thoracic volume decreases, the pressure within the lung rises, and air can flow out. So this is driven by the natural elastic recoil of the lungs. And it's helpful to think about this like a balloon. So once that balloon is stretched, it naturally wants to recoil and deflate and push the air out without any additional energy, so making it passive. So overall, your inspiration requires effort, while your expiration relies on the lungs' inherent properties. In clinical terms, at rest, the diaphragm is dome-shaped and there's no net air movement, but during inspiration, the diaphragm contracts and flattens, increasing that intrathoracic volume and lowering the pressure. So air is drawn into the lungs, and again, it's an active process. And during expiration, the muscles relax, the diaphragm returns to the dome shape, the volume decreases, the pressure rises, and the air is able to flow out. So a passive process driven by elastic recoil is the bottom line. So just to apply this clinically, and we're coming up on our final point here, but clinically, CPAP or PEEP helps maintain alveolar recruitment at an expiration, and we know this, at the bedside for why we keep our babies on a certain amount of positive pressure. So keeping the lungs at a higher resting, it helps maintain alveolar recruitment and expiration, keeping the lungs at higher resting volume. When the alveoli are already open, it takes less pressure to generate the next breath, so the work of breathing is lower, reflecting a lower elastance, with the lung being easier to stretch because there's reduced recoil forces. Now, if CPAP is removed, those alveoli are going to want to collapse and your lung volume is going to drop. So each breath has to reopen the alveoli, which requires significantly more pressure. So for preterm infants, that translates into increased work of breathing, the potential for fatigue, and a higher risk of recurrent atelectasis. So this is a high elastin state. Lung is stiff, with increased recoil due to atelectasis and surfactant deficiency. So just to drive the point home, in preterm infants, surfactant deficiency leads to high elastance, meaning the lungs are stiff and resist expansion. And what that translates to is that even when you apply pressure, you only get a small change in volume. So the lungs are difficult to inflate. And importantly, they also have a strong tendency to recoil back to their original collapse state. And that's where that CPAP becomes critical and acts as a pneumatic splint. So again, here, just to illustrate the point that compliance and elastance are inverses of each other. And then just to quickly summarize our definitions and equations. So our resistance, or Poiseuille's law, is the resistance that is directly proportional to viscosity and length of the airway and inversely proportional to the radius of the fourth tower. Compliance, I refer to as a CVP, just to help me remember the formula. Compliance is change in volume over change in pressure. The law of Laplace is our pressure is equal to twice the tension divided by the radius. Our time constant is our product of our compliance and resistance. And then if you can remember one or the other, the elastance is the opposite or the inverse of our compliance. So is the change in pressure divided by the change in volume. And then our Boyle's law states that as the pressure increases, the volume decreases. So that is, I think, everything that I had in this whirlwind and math-heavy review. If there are any questions, I'm happy to take them or to go back to anything that maybe I went through too quickly.
Feel free to write it in the chat, or if you wanted to like unmute yourself and or raise your hand, we can also do it that way. Thank you. This was actually a great review. I feel like this part is always something I need to re-review. And it's one of the, I think, harder things that we have to kind of grasp, especially for boards.
Yeah, it is. And it's if you're not somebody who can memorize or who likes to memorize, it can be really tedious. So I think just trying to apply it daily in clinical practice is really the way that it's going to stick without making it seem like a chore to learn about it. And the more I think you think about it at the bedside, the more that you can reason through it in clinical scenarios on the boards as well.
Very true.
All right. If there's no more questions, thank you to our lovely moderator today. Thank you to Dr. Sloan. And just a reminder that we will be back in May with Dr. Ryan McAdams talking about AI-ready neonatologist, which should be a really interesting kind of different talk than what we've been doing this year. So we're looking forward to that. So please join us in May.
I did have a question if no one else has
Yeah.
them. I was thinking about this, but something that there's two things I struggle with on like a practical basis. So one, when you're asked to like troubleshoot the vent, do you have in your mind like how you go through what to look at? Do you look at the flow loops first, or do you look at the pressures and tidal volumes, your PIPs, and then do you look at the flow loops and then you try to assess what might be the problem as to why you're still having work with breathing, the pressures are really high, and things like that.
Mhm. No, that's a great question. And I think you really just have to have a systematic approach to it. I would say I really first look at the baby,
Mhm.
look at my tube position, and make sure that we're taped where we need to be, and make sure that, is the baby looking like the ventilator is no longer delivering what they need to? They have terrible retractions. And then go to the ventilator. So I look at my loops. I look at the what the settings are in terms of my eye time, my set tidal volume, my PEEP, and then think about where is this baby in its disease state. I think one of the things that we are seeing, I think especially as we're having these smaller and more premature babies, is that I think that the transition to chronic lung disease pattern is probably happening earlier than I was taught to think about it. So, I would think of like our BPD and kind of needing those low rate, high volume, high PEEP settings as many weeks into their disease course. And I think what we're seeing with some of these sicker, smaller, more premature babies is that with there being so much inflammation so early on, I'm finding myself having to transition from these RDS to these BPD settings, sometimes even around 3 weeks of life or so. Um, so I think we sort of get stuck in the loop of just making these real-time adjustments based on the FiO2 or based on the gases. But if it seems like the baby's being under supported, just think to yourself, has something changed? Or is this baby really just evolving in their disease process?
Right, right. And then the second question I have is, I think sometimes it's easy to know when you need to like get to the oscillator or, change your ventilator itself. But sometimes I have trouble between like volume mode and AC mode. And I wonder if you have like a easy way to think that through and get to that sooner than, arrive at that conclusion a little bit sooner than the general physician would.
Yeah. I mean, I think it's such a stylistic question. I tend not to use AC a ton unless I feel like my baby is pulling volumes or pressures that are maybe unreasonable and just maybe the synchronization is off. Um, but for me, really going back to the oscillator, I kind of tend to think about it in kind of two big buckets of when I would use it. So first being like, do you need that high descending pressure with the high mean airway pressure? And the second really being in the early neonatal period for a lung protective strategy. We tend to not use a ton of the jet in my institution, just culturally. Um, uh, and then I find that in sort of an older baby, so your 2 month old X23 weaker, um, the disease process sort of being in that BPD stage now where they're dependent on that high volume, low rate um, strategy, the oscillator is sort of counterproductive and can really be even kind of agitating to them. So I don't reach for it as much in an older baby with kind of chronically stable lung disease, unless there's like a very acute change where you think maybe they're entering pulmonary hypertension or something like that. Um, but I think for me personally, the distinction in whether to use SIMV versus AC is I'll always sort of reach for SIMV first unless uh, it feels like the baby is sort of pulling unreasonable pressures or volumes because it's just not sensing what it needs to from the baby. And we sometimes with our ventilators here, we have that issues. We don't have the Drakers, unfortunately. So we have the Puritan Bennetts, which sometimes are a little unreliable on the really little babies.
I've seen both because where I trained, we had the Puritans, and then here for fellowship, we have the Dragers. But we're getting the Jet, so I feel unexperienced with Jet and don't know like how to do all of that yet. So yeah, and then I always like to ask any neonatologist that I meet, what's like one piece of advice that you like to give trainees?
Um, Gosh, so much, but I would say I think um everything is can be a learning moment. Um, and even the most kind of low acuity baby that seems so boring and unexciting in the moment, I think has taught me so much, whether it's just about um, the use of a slow flow versus a fast flow nipple, and like that can be such a big thing that you can troubleshoot, but in the moment you're like, I really don't want to think about this because I'm really worried about the baby next door who's on three pressors and I can't oxygenate. So just not dismissing sort of the lower acuity situations that we get called for, because by the end of your training, I think the things that you are really comfortable with is taking care of the really sick babies. But the babies that I still struggle with every day are the babies that really aren't that sick, but clearly something is going on. And you just can't decide if they're really sick or not. So I think everything is a learning opportunity. Every quote unquote boring transport I went on, or every kind of silly seeming call from the term nursery has really kind of taught me a lot about triage and just recognizing sick versus not sick.
Love that. Thank you so much.
Yeah, of course.
All right. Thank you.
Yes.
Thanks, everybody.
See
Thanks for
everyone next
having me.
month.
Bye.